Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome to the Concussion Corner podcast. My name is Dr. Jessica Schwartz, and I am your host for this evening. It is my absolute pleasure to welcome Dr. Erin Reynolds, a wonderful neuropsychologist in the field of concussion and care management. Dr. Erin Reynolds is a clinical neuropsychologist who specializes in the treatment of sport-related concussion. She's an adjunct professor of orthopedic surgery at Texas A&M University. Dr. Reynolds has served as fellowship director for the UPMC, University of Pittsburgh Medical Center Sports Medicine Concussion Program, and has held an appointment as assistant professor of orthopedic surgery at the University of Pittsburgh. She is actively involved in ongoing research projects and is currently a frequently invited lecturer on the topic of sport-related concussion at a local as well as national meetings. Dr. Reynolds, welcome to Concussion Corner.
Thank you so much. I'm so happy to be here.
I am thrilled to have you on board as well. You know, you kind of came on my radar a few years ago. I think when I saw you on Twitter for the first time, and then I started correlating your name to a couple of research papers that were coming across my desk. So it's been great to get to know you over the last few years.
Yeah, it's definitely a small world. Social media makes it so, which is nice because we're all spread out all over the country here.
Yeah, I absolutely love social media for healthcare, moving just thoughts and conversations forward. It's real time, and essentially you can walk into a room and feel like you know people before you've met them in person.
Absolutely, it can be a little bit daunting, but I think overall it's a good thing, and it's a uniter in our field.
Absolutely, especially when we're in the world of interdisciplinary care management across for
absolutely. Well, right, because I go to my conferences and they're so focused, and I may never have the chance to talk to a group of physical therapists. So it's really nice in that way.
Awesome. Yeah, I concur. And it is nice to see, neuropsychologists, physical therapists, physicians kind of showing up to these other conferences that aren't quote unquote their own, right? So it's been a pretty neat few years to kind of see all this unfold.
I agree.
All right. So, Erin, I know that you did your bachelor's degree at University of Massachusetts in Dartmouth, and then you went on for your doctoral degree in clinical psychology from William James, and then you did your fellowship over at UPMC. Is that correct?
So I did an advanced fellowship, kind of skipped a step there. I did my training at William James, and then I did my pre-doctoral internship, and I actually did 2 years of postdoctoral residency in clinical neuropsychology at the Bedford VA Medical Center in Bedford, Massachusetts. That's right. And that is the medical center where Dr. Ann McKee, I don't know if her office is still there, but it was when I was there in 2010. And so that's really where I got interested in brain injury, because I spent really 3 years observing her doing brain cuttings and learning about the brain in a very exciting way there. So I did that, and then I did an advanced fellowship in sports neuropsychology with UPMC in 2012.
Right. And I know that UPMC is seeing, upwards of 20,000 patients a year just for concussion alone. So I can only imagine that being a wonderful place to learn from.
It was, and I tell this story all the time. I mean, I went from working in the polytrauma clinic at the VA. When I went out to UPMC, I went out to shadow. The one thing I'll say about UPMC is they are very generous with their training. And I went out to shadow Dr. Mickey Collins for 3 days, and I was completely blown away by the volume and the quality of care they had there. So in terms of learning how to manage concussion, it is top notch.
Absolutely. And I think, for me, when I go out there teaching and speaking to interdisciplinary fields, for everything from physician to physical therapy, athletic trainer, and everything in between, I use some of the UPMC, rethink concussion, concepts with the 6 clinical trajectories. And I have to say, I saw, I think it was 2013, Mickey Collins, Dr. Collins was discussing, the role of interdisciplinary care. And he said, it is the smartest person in the room team that's taking care of this patient. And I think that was such a unifying front to hear from, the guy that's running one of the largest clinics in the world.
So the UPMC model is very unique, as I'm sure you know. And for those of your listeners who don't know that much about it, the UPMC program is really driven by the neuropsychologist. So the neuropsychologist, there we always used the term the point guard. Now that I'm in Texas, I like to say I'm the quarterback.
Right.
But so the neuropsychologist really serves as that point person. But the team is the essential part, and the team is why that program is so successful. So it combines physicians, physical therapists, athletic trainers, and it all circles around the neuropsychologist. But when he says that, it should be the smartest person in the room managing this, it's really the person who understands the injury the most and can serve as that liaison to communicate with the other team members and to formulate the treatment plan.
Absolutely. And it really becomes down, from old school language of things that have already existed in the field of medicine, really almost like a care manager. And essentially you have to advocate for that patient that's a brain injury survivor at the end of the day, whether it be, an acute concussion that may, neurophysiological or clinically resolve within a few weeks to a month, or someone who may have persistent symptoms and, go past that 3-month mark and get diagnosed with the quote unquote post-concussive syndrome. So, it's really wonderful to see just folks advocating to advocate for the patient and put the patient first.
Yeah, it's so funny because I feel like case manager has such a negative connotation, but if I should probably start logging all of the time that I spend on the phone communicating with the treatment team, and it really, that's what it boils down to. It's a different type of case management than we're traditionally used to, but it truly is that aspect.
Yeah, and I use the language care manager, and I advocate for putting the care back in healthcare. And I had the privilege to meet Marilyn Spivak, who was the godmother of the Brain Injury Association, and she states it herself. We were speaking about this over when we were over at NIH a few weeks ago, and she was like, "There's no other injury in this world that is so underfunded and is so stigmatized." So it's really just wonderful to see folks with a consistent voice like yourself advocating and caring for patients in the best way we know how in 2018.
Yeah, I agree. It's an exciting time to be doing this work, I would say.
Absolutely. So, this is a podcast, strictly devoted to healthcare providers, from an interdisciplinary realm. So it's going to be, kind of giving someone a lens of, what someone else's day looks like. And essentially, here's what I can do for our mutual patient. Here's what you can do for our mutual patient. And here's how we can work together. So I'd love if you can give, a lens to our listeners about, what is a neuropsychologist and kind of a little history on neuropsychology.
Sure. So neuropsychology is essentially of clinical psychology. My doctorate is in clinical psychology. So in my training, I did the practicums in psychotherapy, and I worked in community mental health. And you'll find that most neuropsychologists come from that clinical psychology background. There are a few pure neuropsychology programs, doctoral programs in the country, but most stem from that clinical psychology background. So the study of neuropsychology looks at the relationship between the brain and behavior. So how brain functioning affects human behavior. And traditionally, neuropsychologists, really the cornerstone of neuropsychology is the administration of neuropsychological tests, which we then score and interpret and then provide feedback to the patient that can give them an idea of their cognitive strengths, their cognitive weaknesses. We can use that information to diagnose neurodevelopmental disorders, learning disorders, neurodegenerative disorders. And the cool thing about neuropsychology is that you can do a lot of things with it. And I think what we'll see over the next 5 to 10 years is a shift in, as young people come into the field and have different interests, we're starting to shift away from that traditional sitting across a desk and administering, 4 to 5 hours worth of neuropsychological tests into something a little bit different. And a lot of that also is dependent upon, the state of the healthcare system and what insurance companies are willing to pay for. But there's definitely some tides of change coming, I think, in neuropsychology. that'll be interesting to see over the next few years. So to call yourself a neuropsychologist, the path is typically you have your doctoral degree, and there are specific guidelines. They're called the Houston guidelines that most of us will abide by in terms of what our training consists of. So at minimum, the predoctoral internship and the 2-year postdoctoral residency are the criteria to call yourself a neuropsychologist.
Got it. And in terms of, I had the privilege to, give the keynote at the Brain Injury Association conference for New York State in 2016. And Dr. Stephen Flanagan, a physician here out of New York City, was speaking, and he had such a great line. And he said, as he was speaking to the audience, he was like, the difference between a concussion or a concussive injury and a musculoskeletal injury are the cognitive and the behavioral components. Now, myself as a physical therapist and a concussion post-concussion syndrome survivor, I also add the environment is so important. So, in terms of biopsychosocial factors of poor outcome that you're seeing probably on a regular basis, can you maybe walk the listener to, the role of neuropsychology in specifically for concussion management and where your role kind of fits in?
Absolutely. So, this is where I saw my shift in interest. Like I said, at the VA, I was working in the polytrauma clinic. And in that setting, I was in a much more traditional role. I would administer the neuropsychological tests. I would understand where someone might be struggling from a cognitive perspective, and then I would provide that feedback and maybe do some cognitive rehab. And honestly, a lot of times the veterans and the patients that I treated weren't getting better. And so, I think that in terms of concussion management, neuropsychologists actually bleed a little bit into the world of rehab psychology and rehab neuropsychology, in that you have to understand the whole person. And so the psychological component is so important. The cognitive aspect is so important. But more important is putting everything together. You said something about the environment. I treat mostly adolescents. Adolescents to college age is kind of the bread and butter of my practice. Think about being a high schooler today. You have home stress, you have school stress, you have social stress, you have the internet, social media, that's a big part of their lives. And any one of those areas, if something is not perfectly attuned to where you are as a person, that's going to affect you even if you don't have a concussion. So I know I'm getting a little bit off track here, but the point is, as a neuropsychologist, relying on the training in basic clinical psychology and basic human psychology, understanding how someone operates in their environment, within their family system, within their social system, understanding how movement is playing a role and what it means to them to be part of their team. All of these aspects are critically important. You can't just give them a test and say, oh, your processing speed's a little bit low today. That doesn't mean anything in the grand scheme of who that person is.
Absolutely. And so well stated. And, just to kind of hop on that idea that you just stated with your adolescents and college age, patients that you're working with and clients, what are you advising? I don't know about you, but I'm seeing folks that reach out to me and they're seeing 5, 10 plus providers before they can find appropriate care or the right care. What are you seeing in terms of either I don't want to call it mismanagement because we're here to build up other providers, but what are you seeing consistently with, misinformation to patients, for example, kind of a wait and see approach, other clinicians not understanding that this is a rehabilitative injury. I'm seeing folks consistently 12, 14 months out and, physicians and other clinicians are just kind of doing a wait and see approach. What are you seeing consistently out there that we can, just do better as a healthcare provider?
So here's what I've realized, and this has really come to light for me. I left UPMC in August, and it's now January. So I've learned a lot in these last few months, being outside that little protective bubble, that well-oiled machine. And here's how I think about this. I am a specialist in concussion. As a neuropsychologist, that is where my focus is. So if there's a new advancement in Alzheimer's disease and you want me to see your grandfather who has Alzheimer's disease, I'm probably not going to know about that new advancement or how to implement that because that is not my area of expertise. Mm-hmm. And so I think what happens is it's not because I'm not saying, oh, you're not a specialist, you can't do it. As a specialist, as an expert in concussion, I read about concussion constantly. Mm-hmm. I do continuing education. I talk to other professionals in the field. I eat, sleep, and breathe this injury. Right. And so and here's the thing, right? I'm in a suburb of a city. I was in Pittsburgh before. So we have to think about rural America where you might have one pediatrician or one PCP for the whole town. Are they going to have the time and energy to devote themselves to becoming concussion experts? No. So I think the important thing is this field has evolved so much in just the last 5 years alone mm-hmm. that I don't expect everyone to be completely up to speed on what we're doing in terms of treating the injury. But if you're not up to speed, I think you have to recognize that. And that's when you have to either ask for help or help the patient find the appropriate resource. It's a tricky place right now. Down here in Texas, there's an orthopedic surgeon on every street corner. I understand people don't want their patients to walk out the door and maybe to lose that patient stream. But I just think it's important to understand what you do and don't know and how to effectively help the patient get better. Because at the end of the day, that's should be our number one goal.
Yeah, and if I could give you a high five and a chest bump and all the good things just for that statement, that would be awesome. We're so in line there. And, one of the central tenets that I speak about publicly is, we have to be comfortable with ourselves in a low ego environment. And let's be honest here, being called Dr. Anything is a high ego environment. And we have to kind of be mindful and kind of sit ourselves down occasionally just to kind of reset ourselves as clinicians. And, I say, from my perspective, I created the program that I created because I said we have to advocate for the N of one. We're such in a randomized controlled trial world that we live in with research, but we have thousands, tens of thousands, hundreds of thousands, if not millions of patients being mismanaged. And I really feel like the mismanaged patient in the concussion world is more prevalent than the well cared for one. So from a provider standpoint, I really advocate for folks to really self-reflect and say, you know what, if you really don't know what's going on with the patient in front of you, tell the patient, I don't know, but I'm here to help you find out. And that's, reaching out to, someone like yourself or so like myself or anyone else that I'm going to be having on these podcasts. I always say that I'm not an expert in anything, but I'm wildly passionate about this injury, and it's the same for me. And I think touching on the importance of that this is a post-professional educational journey. This is postdoctoral level training that you have to kind of go through from an exposure and learning standpoint, and you have to kind of bury your heads in the books and just kind of network. What are your thoughts on that in terms of, post-professional learning, really across all fields?
So, and my academic appointments that I've held and that I continue to hold, unique appointments. They don't happen all over the country, but mm-hmm. now I'm educating medical students and residents. But this is not a full semester course or anything like that. They're spending time with me in the clinic, and we're doing grand rounds and things like that. Most of the time, most of the physicians I talk to and the orthopedic surgeons, the sports medicine doctors, I'll ask them, how much time did you spend in medical school learning about concussion? Most mm-hmm. of them say, one lecture. Mm-hmm. Neuropsychologists, now new up-and-coming neuropsychologists, this may be different. And certainly I have training in traumatic brain injury. But the day I walked into that clinic in UPMC, that was something completely new to me. That was something I had never seen before. I had never really read about that treatment they were doing before. So you're absolutely right. This is not something that you're taught in your program. This is something that you have to actively initiate. And, this is something that I've said. I know I've said this on Twitter. I've said this in other public forums, and this is something that I probably get some heat for at times. But the title that you carry, the letters after your name, don't necessarily they don't necessarily mean what you think they mean or what someone else thinks they mean. And so what I mean by that is, just because, yes, I think a neuropsychologist is a crucial team member in the management of concussion, but just because you're a neuropsychologist doesn't mean you're going to be the right person to treat the concussion. Just because you're the sports medicine physician, that title, that name, you have to put the time and the energy in behind that to understand what you're doing.
Absolutely. And in our year-long professional program that I created, that's post-professional, postdoctoral, and interdisciplinary, I spend months talking about cognitive bias, degree bias, cognitive biases as well, but degree bias, and it doesn't have to be an MD-DO or PhD or PsyD or DPT after your name or even ATC. We have to make sure that folks are, ethically, promoting what they can do for a patient, and also ethically knowing, like, hey, a do no harm approach, that we take that oath, when we become doctors of anything, clinical doctors especially. So I think that's wonderful to hear. Kind of shifting attention, no pun intended. We know that the concussive injury is, made up of that differentiates itself from a musculoskeletal injury based off the cognitive and behavioral and environmental components of the injury. Can you take me through, the importance of memory and attention, as a part of your neuropsychological background?
Absolutely. So probably, I would say the most common complaint I get when I'm asking people about their symptoms after concussion relates to memory. And it's funny because everyone thinks they have such a bad memory, and then they start telling me their memory problems. I'm like, no, I have all of those too. But really, people's perception is that, they wind up with these awful memory problems. And part of what's happening here is, specifically in my practice, we have kids that are in school and have an insane amount of pressure on them to perform, and it's a very demanding environment. But also, if you're working with adults and they have to go back to work, memory is an important piece of the puzzle here. And so, if we're going to talk about memory, you have to kind of break that down a little. When someone tells me they're having problems with their memory, I first start asking questions like, can you please be more specific? Are you telling me that you can't remember events in your life? Can you not remember, what you had for breakfast? Is it that you studied for a math test and you can't remember that information? There's so many iterations of memory problems that it's important to understand what they're talking about. Because if they tell you, I can't remember the first 16 years of my life, that's a different animal than I can't remember what I studied last night.
Absolutely.
So what we see with concussion, what I see with concussion is, although it feels like a memory problem, it's typically not a true memory problem, but more of a problem with attention. So if you think about the process of memory, there are three main components. The first is you need to encode the information. And so encoding the information is taking it in visually and processing that information in your brain. And so there's a number of things that can get in the way of proper encoding of information. You could be distracted. You could have an inability to sustain attention, and you're working outside of that time frame. You could be experiencing changes in your mood, like feeling depressed or anxious. There are a number of things that could get in your way of good encoding. So the second part is, once you've encoded that information, you have to properly store the information. But the caveat here is, if you haven't properly encoded that information, you're either going to store misinformation or you're just not going to store it at all. And then the third part of memory is you have to be able to retrieve the information. And again, any distractions, any changes in mood, fatigue, all of these are factors that can then inhibit that retrieval process. So, when I hear memory problems or memory disorders, I'm thinking more of a neurodegenerative issue. And so with concussion, mild traumatic brain injury, what we really see is it's more of that baseline attention that's just completely throwing off the entire memory process. And so it's really about getting to the root of the attention. Is it a true attention problem? Is it a mood-related attention problem? Is it cognitive fatigue? What is the cause? Where's the aberrant signal in the brain that's causing you to have this baseline attention problem? And if you can figure that out, which is not always an easy thing to do, typically you can help the person to get back on track, and then all of a sudden you see improvements in memory.
Mm-hmm. And, I take that and oh boy, do I dumb that down a lot when I speak. But, I talk about Norman Deutsch's book, and he really talks about the, muddy in, muddy out. And I think that's so fantastic that you brought up with encoding, that you brought up the visual component of encoding. We know that 70% of our sensory environments are, taken in through our vision. So, the ocular motor component and vestibular component, but I'll focus on the ocular motor visual component, is so important because we know that about 2/3 of our brain's pathways are devoted to vision. So if we're not taking in information incorrectly, then we definitely can't output it. And that's so wonderful that you just broke that down from encoding and storage. Now, you said there were 3 parts there, Erin. There was encoding, storage, and then was it retrieval?
And then retrieval, right.
Then retrieval, yeah. And I think that's so important. And, that really makes people feel sane, right? So we have folks that are coming in that can potentially be very high-functioning type A folks, and they're self-aware that they can't function properly in their social environment, whether that be professional, personal, or familial. So, that's wonderful to hear. Shifting in that, that same trajectory, I know we have a few minutes left here on this episode, but Grant Iverson does a great job about discussing the biopsychosocial factors of poor outcome. We have pre-morbid injury factors, and I think a lot of folks don't really pay attention to those components of a concussive history, or maybe are not aware that they are so important. And quite frankly, I really feel that the pre-morbid injury factors of a patient are just as important as the mechanism of injury and how they're functioning post-morbidly. What are your thoughts there?
I agree 100%. Having a good biopsychosocial history is so important. And, there's a slide that I show that it's a UPMC slide. You've probably seen it at some point, that really outlines the whole process of our evaluation. And understanding someone's pre-morbid risk factors and their biopsychosocial history can help you to start to prognosticate about where this injury is going to go. If someone, it's all about their underlying factors. Someone who maybe has struggled with some underlying anxiety. We all have some underlying anxiety. But for the most part, people learn to compensate for that underlying anxiety and can get through life without it overtaking them. If you have that propensity for anxiety and then you get a concussion, all of your years of compensation may go right out the window. You may decompensate. And then all of a sudden you have an anxiety problem. And people will say, oh, the concussion caused this anxiety. Well, no, it was always there. You just had a different ability to manage it. But it still has to be treated. It's still anxiety. We have to treat it for what it is. Someone who maybe had a borderline learning problem or an attention problem, they were never diagnosed with ADHD, but it was always kind of bubbling under the surface. They get a concussion and they are really struggling in school. And I've had so many patients come to me where people have diagnosed them with ADHD from their concussion. And I understand how it looks like that and why they think like that, but that's not how the brain works. The concussion didn't give you ADHD.
Right.
So understanding that psychosocial component is so important, and having that good history is critical in understanding the person's recovery.
Absolutely. And I think we'll leave the listeners a little bit on the edge of their seat when we do our follow-up episode together. I know we're going to get into more discussion of what computerized neuropsychological testing is, the benefits and pros and cons of them. But I think just to kind of lead in a little bit, what we're often seeing in global perspective, right, are computerized neuropsychological tests given in incorrect environments, given to the wrong students that shouldn't be undergoing certain testing. Can you maybe discuss and maybe give the listener just a blip of information before we go into our next interview together for episode 2 of this interview? A student or patient or client with a history of ADHD, learning disability, anxiety, depression, genetic vulnerabilities. Can you discuss, why that that patient or that student athlete just wouldn't be appropriate for global mass testing of, in a room for computerized neuropsychological tests, maybe at their middle school or high school?
So I think there's two major flaws with baseline testing right now. There's exactly what you just described. There's, you fill in a computer lab and every kid is sitting next to each other and you're all just typing away on the computer. And then, and this I've seen more since I've moved, there are the coaches and athletic trainers in schools that simply give you a code and say, here you go, take this test online. So you may have kids taking a baseline test in front of the computer with their brothers and sisters in the room. I mean, there's so many issues with this. So I know we're gonna talk more about baseline testing, but yeah, those kids who have a hard time in the classroom environment and you're trying to get a good solid baseline of how they perform on this test, there has to be accommodations for them. There has to be a better way to get that data. And it's the garbage in, garbage out, right? What you're getting in that setting doesn't mean anything. It's not going to be valid testing. And that takes a skilled clinician to be able to look at that baseline when that patient walks in your door 6 months later with a concussion and say, this baseline is garbage. We can't use this. So I think that's a conversation for another day, but understanding how to administer baseline tests if you're going to use them, how to interpret the data, and how to identify what kids need to be tested in either a different environment or a different modality is very important.
So good to hear. And we'll kick off our next episode with that thought process there, Erin. What I like to leave folks with is some kind of, foam ed, and hashtag foam ed means free open access medical education. I know you're involved with the Sports Neuropsychology Society. I was wondering if you could go into, discussing some key characteristics and attributes that you're looking for in your other sports neuropsychologists that are out there that are doing great work. So people around the country and around the world can kind of reach out and find someone like yourself.
Yeah. So the Sports Neuropsych Society is it's the SNS, we call it. It's actually a really young organization. It was established in 2012, and it's really just a group of like-minded neuropsychologists who are involved in concussion management at all levels. And if you're a neuropsychologist in the country or in the world, I believe we have international members, and you're being asked to take on concussion patients or to work in this space, and maybe you don't feel like you're qualified or you don't have the background to do it, this could be a great resource for you to learn more. We have a very active listserv. We can talk about new research, problematic media coverage. We talk a lot about establishing community initiatives. And also, I'll put a little plug in for this because the SNS has a conference every year. So this year in 2018, it's going to be in May. I'm just looking. It's May 3rd to 5th in Washington, D.C. And this conference is designed to be multidisciplinary. So we will have physicians, physical therapists, athletic trainers, occupational therapists. Anyone is welcome. And I'm actually the speaker liaison this year. So while I can't yet disclose our lineup, I will tell you it's a fabulous lineup. Last year, the keynote speaker was Brian Hainline, who's chief medical officer for the NCAA. And it's just a great combination of clinicians and researchers and people you would not typically probably run into coming together and talking about the management of sport-related concussion. So it's a great organization. The website is sportsneuropsychologysociety.com. It's under construction right now, but it's a great resource.
Awesome. And how can our listeners reach out to you?
So they can find me on Twitter at Dr. Erin Reynolds. If you're in the Dallas-Fort Worth area, my clinic website is mystarhealth.com. It is also under construction, but should be up and running in the next few months. And it's probably easiest to reach out to me through Twitter, honestly.
I'm the exact same way.
Yeah, and then I can usually direct them, to a more secure place to talk if they want to. But that's probably the best way.
Awesome. Well, Erin, thank you so much for coming on to Concussion Corner today, and I'll look forward to pushing all this information out to the interdisciplinary world of concussion care.
All right. Thanks, Jess.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.